So, hi, everybody out there. I'm Scott Murray. I'm a consultant cardiologist in Liverpool. I'm interested in preventing heart attacks. As a group, we've decided to come up with a podcast to give people the right information so that they can listen, hopefully enjoy, and try to get a bit more information about how we see heart disease in a clinical practice, and tell you what we tell patients so that you can know before you get into a problem or develop heart disease. So it's almost like a prevention podcast. We haven't decided the name of it yet.
Two hunks and a heart attack.
John wants to call it Two Hunks and a Heart Attack. I think I'm the heart attack.
Yeah, you're the
you
heart
guys
attack,
are the
yeah.
hunks. So we've not decided yet, but we're getting off the ground today. So I think today's going to be about introductions. We're going to talk a bit about how you go from having normal heart arteries, having normal heart function, and how things go awry in a way. So I'll hand you over to my colleagues. So Tom, do you want to introduce yourself?
Yeah, hi everyone. My name's Tom Heseltine. I'm a cardiologist as well in Liverpool. I've been working both with Scott and John now for nearly a decade. My interest is in cardiac imaging with a slant towards preventative cardiology and longevity. Part of my academic interest, as you know, is in and around heart disease risk, particularly with reference to HIV, people living with HIV, which I'm sure we'll cover in one of the charts.
Yeah.
It's got a lot of cross-correlation between how general populations, people living without HIV, develop heart disease. So it's really interesting, and obviously we're going to talk about that and go through it.
Yeah. John, do you want to give us your intro?
Thanks, Scott and Tom, for those very formal introductions. My name's John Hung, and I'm an
alcoholic.
Yeah, sorry, no, wrong podcast. I'm a 40-year-old man. I ride the bike.
Oh,
I'm 40.
Jeez.
Well, I'm 41 this year.
Wow. Time flies.
I've got a family. I've got a wife and 2 kids, and I like traveling. I like playing football and watching football. Key fact is that I'm an Evertonian. But
This isn't a Lonely Hearts column. Come on. We're on a budget here. We're on a timeline.
This is very much yin and yang style as well. I was very
Well, the formal introduction is that I am an interventional cardiologist. So my day-to-day work involves dealing with people who have coronary artery disease. And there's a whole spectrum of people who have just detected it and need something done about it to prevent something happening, to people when it's a bit too late and they have a big heart attack and they get rushed in under a blue light and need something done urgently to save their life. So that's what I do. So I'm a doctor by trade. I'm not a surgeon. Another important distinction to make, but I am interventional. So I spend a lot of time in a sort of operating room, going inside people's hearts and coronary arteries. And essentially, if you've heard of them before, I put stents in. That's most of what I do, as well as the usual outpatient and ward type work that we all engage in. So, you know, we all have different sort of perspectives on this. I mean, You guys are kind of dealing with people with coronary artery disease, hopefully before it happens. And much of the time I'm dealing with it after it's happened or while it's happening. Yeah.
So I suppose that probably ties it up, because we're trying to give information in this podcast to stop people from ending up on your table or having to call an ambulance and get rushed in and get a stent done. I mean, you know, we know that we can prevent that. We know that we can, if you make changes early enough in the right way, that you can stop coronary artery disease from progressing in a lot of people, not in everyone, but in a lot of people. And I suppose that's hopefully what we'll be able to do, is take you from, you know, you're a teenager, you're relatively normal, your arteries are very likely to be normal, to what are you when you're a 45, 50-year-old man?
Speak for yourself.
Exactly, yeah, wreck. Glaswegian jeans, mate. What
I
am I going to do?
Well, listen, that's common to all of us. I mean, to give this a slightly personal slant for a minute, coronary artery disease is one of the commonest conditions that we all deal with as physicians, doctors, in any specialty. Vascular diseases, and it's absolutely pervasive. Everybody knows somebody who's had a heart attack, has got angina, has had a stent or a bypass. And in my family even, it's something I think about a lot, because my granddad on my mum's side died when he was 42.
Yeah.
His brother was 38.
Really?
Aye, yeah. And that's not so uncommon, in that sort of generation and that era. And I'm fortunate enough that both my parents are doing really well. And we can go on to talking about CT scans and investigations later, but I just want you all to know that I've had a CT scan recently and my arteries are absolutely lovely. Is that true of you, Scarzo?
It's not, unfortunately, yeah. So, yeah, a lot of people know, but my arteries are free from disease, but congenitally wired up wrong, or plumbed in wrong.
I didn't mean to walk you into a confession there, by the way.
No, it's okay. I mean, I think it's one of those things. You spent your entire life obsessing over coronary arteries, as you guys know that I did, intravascular ultrasound, OCT, plaque disease, trying to work out why heart attacks happen. Again, similar story to you, John. My paternal grandfather just keeled over in a chair at age 65, so a lot older than your uncle.
It was my mum's dad, uncle. It was my granddad, yeah, and his brother.
So, that started an interest, because I obviously knew how upset my dad was over that. And then to find out yourself that age 45, as I did, that my arteries were not normal and that I might have something that could just switch me off at any point was quite a difficult moment. It's a bit like, I don't know the analogy, but it's a bit like, being a fisherman and getting swallowed by a shark or something like that. Do you know what I mean? But move on from that. I mean, I think it's lasted me 47 years now, so I'm hoping it's going to last me another 47.
My point is, though, it's just like we're
you don't know until you look.
We're thinking about this from a professional standpoint, and as clinicians, hoping to provide education to sort of non-medical people or people who are interested, but it affects everyone. It affects us as well, and so we're definitely not immune from
Tom, have you had your arteries looked at yet?
For my 40th, which is later this year as well.
So you haven't been in the scanner
check
yet?
On my misdemeanors from yesteryear. But I think, just to echo what you said.
Which are minimal.
Minimal, absolutely clean living. But just to echo what you guys have said, there's this sort of, I find amongst some patients, this relaxed attitude sometimes about heart attacks and heart disease. And because I think, as you've said, a lot of people have experience of this and, a lot of good outcomes.
Pop a stent and it'll be okay.
Yeah, that's the people, you can just get it fixed just by putting a stent in, and you sort of walk away and you can have a normal life. But actually the reality of that, it's not quite true, is it, as we know? And you'll be able to, you know better than me, John, about what the mortality is associated with your first heart attack. But it used to be as high as 40%. It's probably a bit lower than that.
But we don't see those people, though. They're just dead.
Yeah.
The best and worst thing about interventional cardiology from that perspective is primary PCI. PCI, let me do a sort of a glossary or an abbreviation segment. PCI stands for percutaneous coronary intervention, which just means going in through the blood vessel, through the skin, basically. Percutaneous means. And coronary means arteries, and intervention is doing something to them. So I say PCI all the time. That's what it means. So the primary PCI means you're having a heart attack. And best treatment is to go inside and open up the blocked artery immediately and put a stent in. And that's one of the things which we're pretty certain of in terms of research and data. That's fantastic, and it's a very good treatment. But also, there are so many patients who start to get chest pain, think, oh, that's bad, call an ambulance. Within 10 minutes, an ambulance arrives. A further 10 minutes, they're at our front door. 14 minutes later, we're inside the coronary arteries. 20 minutes after that, the stent's done and they're getting wheeled back to CCU and they feel fine again. It's almost like nothing's happened.
Yeah. Especially with the drugs on board as well, yeah.
Yeah, the fentanyl helps. So it's important for us, at that point to impress upon patients, you've got through that, but this is something we really need to work on going forward.
Yeah.
And I think the treatment is so good that the reason I say it's the worst thing is because that can be a bit lost.
Yeah.
They've not been keeled over on the floor for the last 10 hours, There's not been a huge degree of suffering. They've had pretty quick treatment and then they're back to normal and they feel back to normal, and that's great. But the reality is they're not normal.
Yeah, 100%.
I think when you say to them, you're a survivor now and 40% of people are dead at home and never make it here, it sometimes gives it a bit of gravity. But I mean, I don't know, obviously you see a lot of patients like me who have not rushed into John, but I've had... Do you want to explain what an acute coronary syndrome is and that sort of lesser?
Yeah. So there's like different, versions of heart attacks, I suppose, which range from, the sort of very acute emergency primary PCI that John just explained, to something that's slightly less acute but equally as important, which is, we call it an NSTEMI, which decoded means non-ST elevation MI, which is kind of, when we're thinking about coronary artery, it means that the artery isn't quite as blocked.
Yeah.
As the sort of emergency, you need that artery opening within the next few minutes. But I think what I'd like to impress on people is that, a heart attack, even if you survive that first one, even if you're lucky, you're still left with the risk of heart failure, chronic breathlessness. Once you've had one heart attack, you're automatically at super duper high risk for another heart attack.
Yeah.
Then you're playing Russian roulette again. 1 in 5 people, it might be 1 in 5, we'll have to check, but 1 in 5 people don't survive a heart attack. So unless you change your ways, unless you are sort of aggressively reducing your risk, then you're playing Russian roulette again.
Yeah.
And I say it, to a lot of patients perhaps that are smoking, which is the classic one, isn't it? You see them, the smoking, unless you stop smoking, and we'll talk about other risks, I'm sure, as we go on, but unless you stop smoking, you're just playing Russian roulette again because you're going to have another event.
Well, I suppose that probably segues into like the risk factors in the introduction to how things go wrong. So let's...
Scott, I want to ask you a question.
Yeah.
Sorry, I feel like I've already become a disruptive force here.
Sorry.
I want to ask you a question.
That's why you're here, John.
Thank you. I'm like, can I be Carl Pilkington?
That's a blast from the past.
Not for me. I listen to it every night.
An idiot abroad, yeah.
That's what I was thinking of.
No, my question to you, Scott, is it leads into the whole thing why you're here, because I think it's important to recognise that you are an ex-interventional cardiologist as well. And so when I was a budding cardiologist and I was trying to decide what I wanted to be when I grew up, you were already in people's arteries doing that kind of stuff.
Yeah.
And you were quite inspiring to me.
Completely forgotten about that, mate. It's like a period of blocked out.
So
mentally. I was on the flip side of that interest.
You were wanting to do it?
Yeah, because I was wanting to do it. And then Scott had recently sort of taken over the lead for the British Association of Cardiopulmonary Rehab.
Yeah.
Everyone can remember that.
Yeah, no, it's such a bad name.
Why did you do that, Scott? Because you changed tack in your career quite significantly.
And it's interesting because you've got 2 influences, one that you inspired to do PCI and one you inspired not to do PCI.
Well, yeah, I mean, it's worked out okay for you guys though, isn't it? Like, I suppose it's weird because my MD was in IVUS, so I was at that point putting IVUS catheters in acute coronary syndromes down coronary arteries in the throes of, an NSTEMI or whatever, to try and look at the plaque and see what was happening. And I think Nick Palmer, who's obviously was my supervisor, when we started off, I was like gung-ho into this. I was really, really, really determined to be an interventional cardiologist and to do the right thing. To what you've done now, John, I mean, you're well established and amazing. So, but by the end of my MD, having looked at all these arteries, I was like, what's the point? Because the artery is diseased from the, don't want to start the swearing, but it's going to happen at some point, from arsehole to earhole, isn't it? So it's basically the whole artery is diseased and we're putting a stent in this one little bit. And I think that's really important when we go forward here and we explain how you develop atherosclerosis, which is the process by which you fur your arteries up, which the end point is a heart attack, unless you do something about it. And that's the whole point of this podcast, is to tell people how to get away from where the route they're in. So, I mean, I think I gave when I handed my MD over to Nick, and he had to read it. He probably wouldn't have read it, but he had to read it because he was a supervisor. He said, "This isn't an interventional MD anymore." He said, "This conclusion is about prevention." And I was like, "Well, yeah." And then obviously the actual day-to-day work of an interventional cardiologist is extremely difficult, and you can obviously say more about it in the modern era. But when I started doing it, you were in the cath lab during the day, we were doing a few ACS cases, some stable cases, and then primary PCI came in, and then it was you're up at night, you're up, I think one Sunday I was in 15 times, and I used to, travel from home. I didn't stay in. And it just the pressure of it got too much for family life. I had 2 small kids. My wife's a consultant. We had 3 rotas. And I think I just thought, why don't I focus on trying to prevent people getting into the cath lab? And I'm still trying to do that. I mean, 10, 11 years have passed. 9 years since I gave up stenting, maybe about. So, I mean, I think that's why. And I mean, now I've influenced Tom, and obviously Tom's research is about accelerated models of atherosclerosis. But I may have influenced you, and you're now, like a dog with 2 dicks. You're, running about in the cath lab doing everything. And that's a testament to how far you've gone, going to London and doing fellowships, et cetera, PhDs. So I think we should focus on how we take a person who's potentially watching this thinking, well, guys, stop waffling. How do I stop a heart attack? How do I get to there? Do you know what I mean? And we should look at it from, you're a teenager right through to your,
yeah, definitely.
You're a surgeon saying you need a bypass. How do you avoid that? Do you know what I mean?
Yeah. So I think it'd be useful to start sort of what is it, and
Yeah. So I mean, go
That was the introduction there, by the way. What you just said there.
Okay.
Yeah.
That was the introduction. After we've all introduced ourselves, what Scott just said, that's the meaning of everything.
Shall we dive into going from normal arteries, happy as Larry, you're a teenager, you haven't maybe started drinking alcohol yet, you maybe haven't started smoking or vaping yet, your arteries are normal, and then maybe start taking us through how you feel things go wrong and risk factors.
There's going to be certain things, isn't there? So we'll probably end up talking about people with certain genetic conditions, sort of abnormalities of cholesterol, people with sort of abnormal energy metabolism, all of the fancy dancy deep dive lipid metrics that you can do now.
So in that vein then, if I can ask you a question, Tom, what is a risk factor? Because we just banded that term about quite a lot. Because I want to make it make it clear. Not everybody gets coronary artery disease. So we just spend quite a lot of time talking about how bad it is and how you might die and all of that, and what to do to prevent it and how important that is. And it is. But there are plenty of people who don't get coronary artery disease and appear to be completely immune to it. So what is a risk factor, and why do some people get it and why do other people not get it?
Yeah, well, this is really interesting. This is what makes it for me so fascinating, because, we've all seen patients that, I give a classic example, someone that might be overweight, someone who's smoking, who's 60 years old, whose father's had a heart attack. Yeah. They come in, we end up doing a CT scan for them, and they're clean as a whistle.
Yeah.
And it's just mesmerizing. You're just like, oh my God. And then
I'm not giving up smoking because my next door neighbour's 96 and she smokes 40 a day.
Yeah. Or when they
still going.
Yeah, when they just have given up smoking, then they come in with a heart attack, and it's all because they gave up smoking.
Yeah.
Oh yeah, I gave up cigarettes and my lungs got worse. But I mean,
you won't believe this, Doc, but I actually packed in the fags a fortnight ago, and now look where I am.
How long is it since you stopped smoking? Oh, yesterday.
But the flip side of that, and we all know this, friends of ours, who are, high level cyclists, for example, not a pound of fat on them, never smoked a cigarette in their life, and, no other risk factors. And they come in, they end up, on the cath lab table a week later. Yeah. Well, having...
That's the whole point.
Yeah.
You don't know,
You
though,
just
do you?
don't
That's
know.
the thing.
Yeah.
I didn't know that my artery was plumbed in wrong.
Yeah.
We knew you weren't wired up correctly. so-
Yeah, obviously. There are people we've seen who you don't expect them to have something, they've got something, and then there are people you're looking at going, oh, mate, this is going to be bad, and then it's not. So it's an enigma wrapped in a mystery.
Of course it is, and this is why it's so important. Not all of this is also discovered on how we traditionally look at, I was going to say the word or the phrase risk factor again. We'll go on to explain it, but not all of it is caught on those simple few questions that we ask patients or GPs or primary care ask patients, when they come in for their well man or well woman check. It's not all caught on that.
And Q risk, again, stabbing in the dark.
Yeah, so that's the traditional risk factor scoring system that a lot of primary care institutions use. But to sort of address your first question about risk factors, so it sort of goes on to sort of how you think about risk and what that means. But I suppose a risk factor, and I was trying to think on my feet because I've never been asked that before. Well, it's something that might push you towards developing coronary artery disease or heart attacks, that kind of thing, that will increase your chance of sustaining a heart attack in later life. Yeah. And that's, the most simple definition I can think of. I don't know if anyone else can.
So if you've got a handful of risk factors, let's say you're overweight.
Let's just run through them.
All right. Yeah. So overweight, smoking, the presence of diabetes, hypertension, a family history of vascular disease, hypercholesterolemia or dyslipidemia, maybe we'll talk about later, bad lipids, and I can't think of any
disease.
others.
Kidney disease, big one.
I think that's about it.
I mean, the main thing is the family history, because there's a whole swathe of polygenic sort of mechanisms that we can't grasp.
Can I quote you?
Yeah, what?
I've said this to about 300 of my patients. So
I know what that says already. You're going to do the accent as well.
I am from Motherwell. So there's
That's a bit Irish.
Motherwell.
Oh, that's better.
Is that in Delhi?
Fuck off. If I swear, I get it better. Fuck off, Scott. No, what was I going to say? So it's genetic, right? Like, so what underpins all of this is genetics. And so you can have all of those risk factors, except for the family history one, and still not develop coronary artery disease because you are genetically advantaged, and life is not fair. And I have this conversation with my patients all the time. That cyclist you were talking about who's really fit, but then ends up on the cath lab and he's got 3-vessel coronary artery disease. And he said, well, why? I've never smoked. I eat fish and veg every day. And the answer in that particular case is, well, it's been passed down in your genetics and you are prone to it, unfortunately. And as a senior consultant friend of mine used to always say to his patients, Shetland ponies have Shetland ponies. So, what's that? What comes out in there's another one. What goes into there's some other aphorism that's a bit like that, but basically you end up, with the same genetics as your parents. And
you're worrying me a bit, because Gavin Lewis, who's one of our colleagues, said to me the other day in front of some juniors, he said, oh yeah, one of my memories of Scott, it was almost like I was dead, and he was talking about me whilst I was there. He said he just stented someone on a primary, walked in, pulled back the covers, slapped the guy on the belly and said, when's it due? And I was like, I must have been really sleep deprived then or something. I was like, that's not normal, and apologies.
Yeah, I think
you have to get the point across to the patients, don't you, in some way, without actually making it real to them. I've always said this: they do need the shock factor.
I think it's a good moment. I think it's a perfect moment, because to us, I'll do 6 of them a day, cases, or 6 patients per day, and 300 or 400 in a year. But for each individual patient, that's theirs.
That's the moment.
That's a life defining moment for that person.
I think it's really tough, this bit, because as you both know, I used to be quite paternalistic with patients. I used to go in sort of just like, say you need to change, and, all of these lifestyle things, that this is what's making you sick. A classic one would be a patient with type 2 diabetes, and they're sat there eating the chips and the jelly, one day after the heart attack, are waiting to come across to you guys for a stent.
Because we gave them it,
yeah. Well, that's another talking point, isn't it? Like hospital food.
But can you note on the agenda, hospital food, please, for later? We'll talk about hospital food.
White toast and
white toast, ice cream, jelly, potatoes, and they don't eat the veg. No matter what they say.
That's another one. Salad dodgers. Yeah. Glasgow's favourite.
But I used to do this, and I've seen loads of patients back, and you say, you need to change. You go through it with them. You exercise. Even if they go to cardiac rehab, which is another talking point. And they come back in. They've not changed one iota.
I lost 3 pounds, doctor.
Yeah. It's really difficult, but I'm still eating chicken, fish, vegetables. Really off. They never have a chippy tea.
CFE.
And and I think one statistic I saw the other day was that in terms of doctors or physicians or a qualified professional giving a patient lifestyle advice, negligible numbers of people change.
Yeah, no.
Was it 1%? In a recent
very, I
BMJ?
think it was 1 in 1,000 achieved all of the metrics.
Yeah.
I might need to check that, but I think it was like, normal blood pressure, normal lipids, adequate sleep, exercise. When you stack it up, 1 in 1,000 achieving that.
Yeah, and you spend all this time going through it with them. And I
probably don't achieve it, to be honest.
Well, yeah. It's difficult, isn't it? And, I end up saying to people, Rome wasn't built in a day, and you see them a year later and, they put on even more weight. They're still smoking the odd cigarette or whatever. But, and I think a lot of that is from a failure of understanding about risk and, about how lucky they are, if they have got through a heart attack without any significant morbidity or long-term effects from that.
Can I defend patients a little bit?
Yeah.
Because we're obviously talking about how all of the time and effort we put into giving them advice feels kind of wasted. But not in every case, but in many cases. But in those many cases where poor progress is made, it's really hard. And we're all, human and guilty of the same sort of things. The Western diet is a shambles. It's very, very difficult to get good food, particularly if you're on a budget.
Yeah.
It's 100%. Much cheaper to go and get a £5 meal deal from McDonald's than it is to go and buy a fillet of salmon from, M&S Food.
You probably get one salmon.
Yeah.
Or one
chippy
slice.
tea, get it there and then.
It's much cheaper to buy carbs and sugar than it is to buy, fish and vegetables. We're constantly faced with the cravings, When we came in then at the front of the podcast studio, there was coffee and Kinder Buenos, right? And I'd not had my breakfast today. So I snaffled about 5 Kinder Buenos there. So
I did raise an eyebrow at that.
Scuffed it, I think it was called.
So it's all very, we're all full of good advice and stuff, but it's really hard to do. And the other risk factors equally so. So smoking, giving up smoking's not that easy. This is what people face,
very, very difficult.
And the thing about primary prevention or secondary prevention or any sort of prevention is that people don't feel that unwell. So if you've got a headache, obviously you're going to take paracetamol, right? Because there's a cause and an effect. If you get told you've got high blood pressure medication compliance is absolutely shocking because you don't feel that you've got high blood pressure. Therefore, there's no stimulus to do it. And so on a daily basis, people just...
Can I just take that point? Because I find that interesting because I find that patients are a bit more emotive about blood pressure somehow.
It's become better, I think, than it used to.
I sense a palpable change there, actually, because people say, my blood pressure, and it's sort of very well educated specifically about that point. But it's just an interesting reflection.
Is that just in your private clinic? You test the piss of hypertensive people.
Taste the piss of hypertensive?
Test it.
Oh, sorry.
Test it. I mean...
That's taking it to a whole new level, John.
You really are there.
Diabetes.
I'm going to separate myself.
Bit sugary.
Dedicated cardiologist that John is.
No, look, I might be outdated here, but in cases of refractory hypertension, difficult to treat high blood pressure. People who are on multiple medications, maybe 4, 5 or 6. The ones that are really difficult to treat, 2 things happen. They come into hospital with super high blood pressure and supposed good compliance.
You give them
They get given all their meds by the nurse the next morning, and their blood pressure hits fucking rock bottom.
They have a watershed stroke.
That's happened to me, you know. Well, no, but that was treating someone with extreme hypertension that wouldn't settle down, and you know, getting to a point 3 or 4 days in where we're like, right, we really need to get this down, or this patient's going to have a bleed, and then it all came down at once, and they ended up having.
Did you give them sodium nitroprusside?
No, but I don't know what happened, but everything sort of washed in at one point, and then the blood pressure really dropped, and they did end up having a watershed.
Oh, right.
Yeah.
Geez, yeah.
So it's anyway, getting off topic.
So what I'm saying
risk
is
factors.
that if you don't feel it, then it's much more difficult to understand or to have the daily impetus to do something
100%.
about it. And therefore, I have a lot of sympathy. You know, for example, if you tell me that I need to take antibiotics for a chest infection for a week, after 3 days, I've lost interest and I'll probably forget the 4th day.
That's just ADHD. The problem is, though, is the other side of the coin is if it's pleasurable as well, then you're not going to give up, are you? You know, if you're stimulating those centers in your brain, you know, pleasure centers, then you're not going to stop smoking when you get pleasure. You're not going to stop eating sugar and chocolate because it's pleasurable, you know, or processed food.
Yeah.
You know, I mean, if anyone's opened a packet of Walker's chili crisps or whatever, or Doritos or something, you know, you can't just have one, just like you can't have one digestive biscuit.
They're made like that.
Yeah, no. So
engineered.
again, that's another food addiction thing. But I think we've been sort of set up to that, haven't we? Because people know what motivates human beings, even down to the fact that we're all scrolling on phones now because we're dopamine addicted. So I think pleasurable things are hard to give up, even if you're faced with the prospect that you might not live as long or you might have an event in the future. It depends on your.
And I think
There's also
sorry,
go on.
I was just going to say, some people as well, you know, you give them all this information and say, well, it's my choice. I want to carry on, you know, eating chippy tea, or I want, because, you know, the reality for some patients is that their, you know, lifestyle, you know, the poverty around, particularly where we work in, you know, inner city Liverpool, the poverty around here is that people's reality of life is, you know, they don't have a great deal.
Yeah.
You know, it's really difficult for people. They can't.
Where is the pleasure?
Yeah, your point, John. You know, they can't afford to go and cook salmon. You know, they can't. They don't have the time. They've got loads. You know, all of these things, and you know, they might not want to give up smoke because they don't have a lot else. That's what they want to do. Or
it's just a value judgment. It's just what's important to you. And
it's a thing called life stage segmentation. They've worked it out. There's only about 5 things. So you can be I think it's a live for today, a DIY health denier, a balanced compensator, which I am. So like, you know, 6 beers and a salmon and broccoli. Do you know what I mean? Or something like that. And then you've got
3 days on, 1 day off.
A health conscious realist, which is someone who is very focused on their health, interprets data, changes their behavior, moves forward. And you know, we don't see a lot of health conscious realists in NHS because they're not unwell.
Yeah.
So
fatalism around here. I don't know what.
There is.
What category that falls into.
Yeah, my dad died at 55.
I've had a good innings.
Oh yeah, you've had a good innings when you're 65 sometimes.
Yeah.
Risk-taking behaviour is a very individual thing. You know, I'm quite health conscious. I exercise a lot, and despite the Kinder Bueno episode a moment ago, Kinder Bueno gate, I actually quite well most of the time. And
you're going to smash that out on the bike later.
Yeah.
Or?
Well, the cat of nine tails is coming out.
I've got my excuses, but you know, if you just accept for a moment that I'm quite health conscious and I eat well and I don't take risks from that perspective, I do ride down mountains 80 kilometers an hour sometimes. And I do ride a motorbike like I came into. And you could say, well, why are you doing that? Because if you don't do that, you've got much less risk of dying. And that's fine. Yeah. But it's a risk I want to take because I like it. And if someone says to me, well, to be honest with you, I love smoking, so I want to carry on smoking. Well, that's up to you. Yeah. All I'm going to do is give you some advice and say, well, it's not going to be very good for your arteries and you might die a bit sooner. But if you say, well, I'll take it, doc, because I like a fag, then that's your choice, isn't it?
Of course.
Absolutely. No, I think we probably need to separate, the life stage segmentation along with, human rights and the fact that it is a person's individual decision. But I suppose what we're trying to do here is to enlighten people to the fact that if you have several things and you don't want to die of a heart attack, then, there are stages along the way where we could say, this will help, watch for this, watch for that. And I think that's probably the goal of what we're going to get to here.
I think, underpinning all of this, I think most people don't want to die prematurely of a heart attack.
Yeah.
I think on that point as well, it's, the first symptom that most people have, leading on from your points, I feel fine. The first symptom not anyone, but the majority of individuals have is their heart attack.
Mm.
That's a classic medical school question: is what's the first symptom of heart disease,
or your death? Sudden
like,
cardiac death.
Yeah.
So that's why sort of people, I don't want to say I'm going to say it, throw caution to the wind. And the dad died age 40. They're still smoking age 45, feel fine, but then bang down they go with the heart attack. They're playing Russian roulette.
How would you like to die?
Yeah.
Like Michael Hutchins on the back of a hotel door with an apple in your mouth. No? Orange instead?
Orange.
I think I'd be able to chew through an orange.
I was going to say Shane Warne, the cricketer, but that's another one. Yeah.
Ko Panyang or whatever.
Yeah. Let's. I mean, we could go down that route. That could be a dangerous,
let's have an in-depth discussion about that.
Let's back up. I mean, I think if we were gonna, I think one of the points we could end this segment on is something that really does grate me is what I've described in the past as Gilb syndrome, and that is genetically inherited logic bypass. And that is when you go to the patient, tell me about your family history, and they say, my dad died at 45 of a heart attack, my mum had emphysema and got a pneumonia and died. And then you say, and what conditions do you have? Oh, I've got asthma, do you smoke? Yeah, 40 a day. And you're like you've watched your parents die of lifestyle related diseases, but then again, you are inflicting yourself with that, knowing surely if you have any logic or any ability to process that you will follow a similar path, being 50% mom and dad. And it's not all the time, but there's sometimes you get that and you're like, how do you, I mean, you say to them, well, smoking's not great for asthma, smoking's not great if you want to avoid a heart attack, but people somehow haven't made that connection.
It's head in the sand territory, isn't it? It's willful denial.
I think we probably need to just sort of say, don't do, if someone in your family's died young, don't do what they did. Like my grandfather had undiagnosed hemochromatosis. He was diabetic. He loved cakes. He used to apparently drink curdled milk out of the fridge. So it had gone off and he'd just tank it. He smoked. He drank too much. He didn't exercise. I've seen pictures of him. I think I was about 2 or something when he died. But the pictures of him, his face looks like a sponge that's been soaked in tomato juice. Do you know what I mean? He's like, and he's,
overweight.
He just never took his tablets, didn't take his frusemide, just keels over on the chair watching Scotland play football in Spain 82 with a can of tartan special and a Jimmy wig on. So, do you know what I mean? I'm not doing that.
That's enough to send anyone over the edge.
My dad isn't doing that. I mean, he does have coronary artery disease. So I think it's like trying to separate yourself from, what's there, and I don't think everyone makes that connection.
So if we're gonna round off for this first episode, we've talked about how coronary artery disease is so common. and to some extent it can be preventable. So if you were to say, Scott and Tom, in just a few words, what do we need to do? What do people need to do to try to prevent them from having their heart attack? Stuff we're going to talk about in a bit more detail later, but what are the main headlines?
I think for me, if you are someone that's particularly susceptible to this kind of thing, and we've already spoken about how important genetics are, for example, if you, like you, John, you've got a significant family history of this, then it's about doing the right things and doing them early. What I end up saying to a lot of people is, you set your habits. You can get away with stuff in your 20s and 30s. You can go and party and, stay up late, have stressful work and stuff. But, what I say to people is like, that's when your habits form, in your 20s and 30s. And then where it gets really important is your 40s, 50s, 60s and beyond. And that's where it starts to become an issue. So in terms of, risk reduction, it's all about getting your lifestyle as optimized as it can be for you, depending on, your health beliefs, your health goals. If you're, wanting to live till you're 80 years old, we've already discussed briefly how you want to die, but if your vision of, your wish for your life is to get to 80 years old and then watch your kids and grandkids grow up, then in order to give yourself the best chance of achieving that. And by the way, this has crossover and parallels with other diseases as well. Your best chance of doing that is by adopting the healthy lifestyle approaches, as well as potentially, having a test to understand your true risk. For me,
I think
I don't really say anything different.
This generation that are coming through, hopefully, are a bit more mindful, even though social media's got its bad elements. I think there are elements on social media that are kind of nudging younger people to be potentially more active and more engaged with their health and the sort of image side of things, Instagram generation, whatever. I would think that I've been asked to do to sort of chair a session at British Cardiac Society this year around population-based interventions and screening for cardiovascular disease, and should we bring it forward to age 25? That's the sort of general debate topic, rather than doing a health check that no one does when you're 40. I think there's a lot to talk about in that, but I'd rather we got some information across to people when they were in their mid to late 20s, rather than when they've already sort of maybe into the secondary prevention category in their 40s. So I suppose we probably end the segment there and come to the next episode.
Do you have any thoughts, John? Anything different to say?
Do you think? I mean,
no. I just want to be
the age of people you're seeing in. What's the youngest you've put a stent in?
28.
Yeah.
Is that with traditional disease and not SCAD?
No, I had FH.
Okay.
That was somebody who had genetically very, very high cholesterol, and those unfortunate people are pretty prone to very young cardiovascular disease. But it's pretty common to be putting stents into 30-something-year-olds these days with bog standard coronary artery disease. Yeah.
So that's probably a good point to move on, as to, we just basically say, how do you get a heart attack when you're younger, and how do we think some people are progressing quicker than others in the next podcast?
Can I be dead show busy and round off the podcast?
Yeah, of course.
That's great, Scott. Tom, well, listen, I think we've covered most of the key issues there, and so many things that we want to talk about going forwards. How to prevent it, some of the treatments that we do, some of the lifestyle things. There's so many issues. So I think that's been really valuable, and I hope that we've given some inspiration there and stuff to talk about in the next few episodes. So thanks to Scott, thanks to Tom, and thanks to myself. No problem, John. And we'll look forward to talking to you next time.